going to discuss an important topic, that is narrow complex tachycardia. I think most of you will be seeing in your emergencies or even in your ICUs and wards many ECGs which are QRS duration will be less than 120 and your rates will be more than 100. There are a wide range of differential diagnoses of this. These are known as the narrow QRS tachycardia. Narrow because the QRS is less than 120 as compared to wide QRS, which we have already discussed in the previous classes, which have a good number of differential diagnoses like a VT or a SVT with aberrancy, or even a patient with pacemaker or a pacing rhythms, or a patient who has SVT with a previous baseline QRS wider like LPBT and all, and in patients who are on certain drugs like class A1, class 1C drugs, and sometimes even hyperkalemia and all. So these are the usually a differential diagnosis of wide QRS tachycardia. Narrow QRS tachycardia are more commoner than the wide QRS tachycardia, and right from the atrial fibrillation, flutter, and AVNRT, AVRT though less common, AVNRT is very common. We see a good number of this ECG in our ICUs and emergencies and in our wards. So when you have a patient with such ECG, it is important to know the diagnosis because it helps in giving the treatment, because not all the patients with a given narrow QRS tachycardia will respond to the same treatment. Second, why it is important to know the etiology, because some of them are reversible by either by drugs or by some procedures known as radiofrequency ablations and all. And we can also know the prognosis of a disease by knowing the diagnosis. So in next 1 hour to 1 hour 15 minutes, we will discuss the important aspects of a narrow complex tachycardia. So as I already told you, what is a supraventricular tachycardia? So most of this narrow QRS tachycardia is actually classified as a supraventricular tachycardia. They can arise either from a atria or the AV node or from the His bundle, and sometimes rarely from a ventricle. So they have a heart rhythm disturbances which are initiated either in the atria or a ventricle at the level of His bundle and all. And the atrial rates are usually more than 100 beats per minute, and so are the ventricular rates. And it requires a tissue above the His bundle to perpetuate it. That is something important. Now, the duration of the tachycardia should always be less than 120. Now, one of the important things which you should know is very occasionally you will see a ECG with a wide QRS tachycardia which looks little narrower, and then you may be confusing it with a narrow QRS tachycardia. Always remember, any patient who has a structurally normal heart and a right bundle branch block type of ECG with a left axis deviation, always consider a fascicular VT. So this is one type of VT which looks like a narrow QRS tachycardia, but it is actually a ventricular tachycardia. Why? Because it is arising close to the septum, that is near the vesicles, and that is why it is a narrow QRS tachycardia. So any patient with the right bundle branch block with the left axis deviation is actually a little narrower, but not a narrow complex tachycardia. The QRS duration in such patient varies between 110 to 130, and that is one thing which you should not miss in your daily routine practice. Now, when you go to clinical, so clinically how this patient behaves, so they can be symptomatic or asymptomatic. Now asymptomatic because you see many of the WPW syndrome, not the pre-excitation. So WPW is something where when a pre-excitation is manifested, so that is when we call it WPW. But a pre-excitation is just a baseline wide QRS which has a delta wave, which has a short PR and a wide QRS more than 120, and that is known as a pre-excitation, and only when it manifests it is known as WPW. So most of them may be asymptomatic, and even patients with AVNRT, sometimes they are asymptomatic. They may not have the palpitations and all, and they can just present and we do a ECG and we find there are wide QRS, narrow QRS tachycardia. And what symptoms do they have is, most commonly do they have palpitations. The palpitations are usually regular and fast rate, and it depends, as I told you in the last class, it depends on the mechanism of arrhythmia. If it is due to automaticity, it is warming up and cooling down, means slow to start and slow to end. Whereas if it is due to triggered activity or a re-entry, there are rapid onset and rapid offset. So the history of this palpitations are important. Most of them are usually fast, but rarely they can be slow rate also. And it can be regular or irregular. Most of the time when it is irregular palpitation, the diagnosis becomes a atrial fibrillation. So there are some other differential diagnosis of irregular palpitations like a atrial flutter with a variable conduction and a multifocal atrial tachycardia. But clinically, the most common irregular arrhythmia is a atrial fibrillation. Now, these fibrillations can be a paroxysmal, persistent, or permanent. These SVTs are usually not life-threatening. Only if the ventricular rate goes beyond 250 to 300, they are associated with syncope. But still then it is not usually life-threatening like a ventricular tachycardia because they have an underlying structural heart disease. And impairment of the hemodynamics is usually not a feature of a atrial SVT. Rarely, as I told you, if the heart rates are very high, they can impair the hemodynamics, and sometimes even a structurally abnormal heart, they can impair the hemodynamics. Now, how do we classify this SVTs? So usually they are divided into AV node dependent and AV node independent. We know the two classic example of AV node dependent are atrioventricular AV nodal re-entrant tachycardia. So there is a circuit between a SA node and a AV node, as I discussed in the last class. Normally, most of the time, the impulse conducts from the fast pathway, and we do not have a slow pathway. And in some of the 1 to 2% of the population, there is this abnormal circuit known as a slow pathway, fast pathway. So normally, what happens whenever, as I discussed, whenever a premature atrial complex happens, after a normal sinus rhythm, the fast pathway is in a refractory period. So the impulse cannot conduct from the fast pathway. It will go from the slow pathway down and it will go to the ventricles. And similarly, when the fast pathway is out of the refractory period, the impulse again goes back. So there is a re-entry. So that is how your AV-NRT, that is AV node re-entrant tachycardia behave. Whereas a atrioventricular reciprocating tachycardia is something where there is something known as a accessory pathways. Normally, we know the impulse from the SA node conducts to the AV node, and from the AV node via the bundle of this to the ventricle. Again, in less than 1% of the population, there is something known as the accessory pathway. Now, these accessory pathways are usually present from the atria to the ventricles, and sometimes this the impulse can travel also from the accessory pathway. Most commonly, it is the orthodromic, means from the SA node to AV node via the normal pathway, that is the fast pathway, and from the ventricle back to the atria via the accessory pathway. That is the most common, and because it conducts from the SA node to AV node to ventricle via the normal pathway, which is a fast pathway, it is usually a narrow QRS. On the other hand, the antidromic AVRT is one where from the atria to ventricle, it is from a accessory pathway. And why it is called anti? Because the anti is in a normal pathway. So the normal pathway, it goes in an opposite direction, in the reverse direction. So from the atria to ventricle via the accessory pathway, from the ventricle back to the atria via the normal pathway. And that is why, because it conducts via the accessory pathway, which is a slow pathway and a higher refractory period is more, that is why the QRS is wider as compared to the orthodromic tachycardia. So that is the basic of a AV node dependent. Now, what are the AV node independent are? We know the atrial fibrillations and atrial flutter because they need a dilated right atria or a left atria. The atrial flutters are usually due to dilated RA, whereas the fibrillations are most commonly due to a dilated LA. Sometimes the SVTs can start in the atria itself, where it is known as the atrial tachycardia. It can start from the atria or from the vena cava or from the pulmonary veins. And there are different types of atrial tachycardia which we'll discuss. Focal atrial tachycardia, intra-atrial, sino-atrial nodal tachycardia. There are different types which we'll discuss. And junctional ectopic tachycardia, which is from a ectopic range from the not from the normal SA node, but from ectopic SA node, which we also call as ectopic atrial tachycardia. Now, before we go into each of this, we should always know that once a patient comes to the emergency, you should always see whether the tachycardia is a narrow QRS or a wide QRS. We have already discussed a wide QRS. You have three differentials: a ventricular tachycardia or a SVT with aberrancy, that is SVT with a aberrant accessory pathway, or the abnormal baseline QRS like the RBBB or LBBB, or patients who are taking drugs like 1A, 1 class 3 drugs, or hyperkalemia, and sometimes because of a ventricular pacing. So these are the wide differential of a wide QRS tachycardia. SVT, when you have, you should always see whether it is regular or irregular. I already told you irregular have three differential diagnoses. So the irregular, most common, it is the atrial fibrillation. It can be a MAT or it can be a flutter with variable conduction. Regular has a big number of differential diagnoses. Starts from the AV-NRT, which is the most common. It can be AV-RT, which is very less common. It can be atrial tachycardia. It can be even a sinus tachycardia. So these are the differential diagnoses. So how do you differentiate this? Is you see whether the P waves are clearly visible or not. If your P waves are not clear, then it can be any of this. However, if your P waves are clearly visible, then there are a few differential diagnoses. Now, if it is not clear, then you have to, most of the time we know when a patient comes to emergency, we do not know the differential. We just know it is a SVT, it is a AV-NRT, it can be AV-RT. Then we have certain clues like a pseudo-S, pseudo-R and all, which I'll discuss. So you give most common a 6 milligram of intra-IV adenosine with given fast and raise the hand so that the action is very short acting. So you have to give it very fast. And sometimes you can give 6 to 12 mg more. So maximum dose is 18 milligram. It has ideally to be given via a central line, but most of the time we give via a peripheral line, but you have to raise the hand so that the drug clears off very fast and it action goes faster. If it terminates with a P wave, suppose if it terminates with a P wave, it is usually AV-RT and AV-NRT. At this point of time, I would like to tell one important thing. If you people pick up, it is very good and it is something like a gold medal question. Any SVT, if it terminates with a P wave, you definitely rule out atrial tachycardia, because termination with a P wave means AV node is a part of the circuit. It means it is AV-RT or AV-NRT. If it's not terminate, if it doesn't terminate with a P wave, it means AV node is not a part of the circuit, which usually happens in atrial tachycardia. So if it terminates after a P wave, atrial tachycardia is ruled out, but it doesn't rule out what other things it can be. If it terminates after the QRS, it doesn't give any differential. It can still be AV-NRT, AV-RT, AT and all. So it doesn't give you any idea. If the tachycardia persists with the AV block, it means the ventricle is not a part of the circuit. You should always remember, if the tachycardia persists with the AV block, it means the ventricle is not a part of the circuit. It means you can definitely rule out AV-RT. So AV-RT is ruled out. So and even a AV-NRT is ruled out in that case. So you have other three differential diagnoses. Now, when you have this diagnosis, sometimes if your P waves are very clear, you have to know few things. If it is very clear and you have 1:1, means the number of ventricle is equal to the number of atria, the atria rate is equal to the ventricle rate, then you see something known as the pseudo-S and pseudo-R. Most of you will be knowing only this one thing about the differentiation of the pseudo-S and a pseudo-R, because in most of the AV-NRT there is a short RP tachycardia. Short RP means the RP is less than 70 milliseconds. Most of the time you may not be able to see the P wave. If you are not able to see a P wave, it means it is definitely AV-NRT. If you are able to see a P wave, but the P wave is immediately buried in the QRS or as a part of QRS, so you are seeing a P wave which is negative in lead 3 and positive in lead 1. So it gives the appearance of pseudo-R and pseudo-S. Then the AV-NRT is most likely. However, if you are then you have to assess the RP interval. If it is a short RP, means how do you know the RP interval? Most commonly you will be able to, you see the RR interval and the half of that is RP interval. So if the P wave lies within the less half of RR, it is a short RP. If it lies after the half of RR, it is a long RP. Now this is very important because the typical differential diagnosis of the short RP is AV-NRT and AV-RT. That is typical. Atrial tachycardia is very rarely a short RP, but it can still be a short RP. Sinus tachycardia is very rarely a short RP, but a variant of it, that is SA nodal reentrant tachycardia, is a short RP tachycardia. And long RPs are atypical AV-NRT, atypical AV-RT, which we also known as paroxysmal junctional reciprocating, permanent junctional reciprocating tachycardia, PJRT, which is an atypical AV-RT. And we have also then sinus tachycardia is a differential long RP, atrial tachycardia is a differential diagnosis for long RP, and SA-NRT is a differential diagnosis for long RP. In all these cases, you have to see the response to adenosine. If it just terminates with the adenosine, it means most likely it is a AV-NRT or a AV-RT. If it doesn't terminate, if it slows down and again reverts back, it means it is a atrial tachycardia or SA-NRT, SA nodal reentrant tachycardia. So if it responds, it is usually AV-NRT or AV-RT. Other things usually do not respond to carotid sinus massage or adenosine. Now on this hand, if you have to see the morphology of P wave, normally in a sinus tachycardia, the morphology of P wave is similar to the morphology of sinus wave. So if the morphology is similar, it is usually a sinus tachycardia or SA nodal reentrant tachycardia. If the morphology is different from the sinus node, it is usually a atrial tachycardia, and the rate is around 120 to 150. Most of it is a regular tachycardia, atrial tachycardia. P wave morphologies are different, and the PR interval varies. So these are the few differential important things about a atrial tachycardia. And then you have to see whether you have a retrograde P waves. So retrograde P waves can be there in anything, AV-NRT, AV-RT, or it can be in a counterclockwise atrial flutter, as we know, sawtooth P wave. So these are the various things. This slide is very crowded, but you should go step by step and understand each of this. Now let's discuss each of this in little detail. Now, when we talk about the sinus tachycardia, it is actually a sinus wave. So we do not have any doubt. Most of the time, we will be able to pick up a sinus tachycardia. It becomes very difficult when it becomes inappropriate sinus tachycardia. Inappropriate means the sinus rate is not appropriate for the age of that person. Usually we say when the heart rate becomes more than 140 to 150, it is usually an inappropriate sinus tachycardia. It is the mechanism is usually automaticity. So it is usually have a warming up and a cooling down period, and that is why there is sympathetic activation of this. Most of the time we usually see this in patients with fever and all, and sepsis and all. As I already told you, there is a gradual acceleration and a deceleration. P wave morphology is similar to sinus rhythm, and that is one thing which will differentiate from a atrial tachycardia. In atrial, most of the atrial tachycardia have a P wave morphology which is different from the sinus rhythm, except the one type which is a SA nodal reentrant tachycardia, which is having a similar P wave morphology to the sinus rhythm. And the rate rarely exceeds 200, as I already discussed. And as I told you, if you give adenosine or a carotid sinus massage, it will slow down, but it will again come back to the same rate. So that is one important thing about the sinus tachycardia. And inappropriate, it means the sinus tachycardia is abnormal to the situation. Now, most of the sinus tachycardia responds to drug like beta blocker, calcium channel blocker, and sometimes the newer group of drugs like ivabradine. So if you have a patient with sepsis and all who is not on inotropes in your ICU, and the patient has inappropriate sinus tachycardia, ivabradine is one drug which acts on funny currents, as I already told you, IF type of ion channels, and that is very helpful for decreasing the rate of sinus tachycardia. It rarely also responds in a atrial tachycardia, but if you should remember, sinus tachycardia is one place where it works very well. Now, we'll discuss in brief about atrial fibrillation, but we'll have a deep class on atrial fibrillation later. So this is one thing which you should not be missing, atrial fibrillation, because it is the bread and butter of a cardiology. Like a coronary, it is a most basic 12 lead ECG you will be seeing in many of your ICUs in the wards. So irregular rhythm where the P waves are not very clearly visible. Sometimes what happens is the P waves are seen. Many people say that there are few P waves are seen and so it's not a atrial fibrillation. It is not like that. You have to see whether there are fine P waves, whether there are coarse P waves. And sometimes a single ECG also can have a paroxysmal AF. So irregular ECG which doesn't have a distinct P wave, you should always consider atrial fibrillation. And if you have in doubt, always auscultate the patient or palpate, because you will get a irregular pulse. So irregular pulse where the apex pulse deficit is more than 10, where the A waves are absent on JVP and your varying intensity of the first heart sound is there, is a typical of atrial fibrillation. Now there are many theories which we'll discuss. This class is not about the theory of AF, but in the next thing you will be asked in your exam, how do you calculate a rate of atrial fibrillation in ECG? Because that is not what is normal of a normal sinus rhythm. So what we do is, we know the normal 12 lead ECG is taken for a 10 second. So you count the number of RR intervals in the long lead 2. So long lead 2, you calculate the number of RR intervals and multiply it by 6. And that gives you the rate of atrial fibrillation. Third important question is, in a patient with atrial fibrillation, suppose you know that the patient had atrial fibrillation or a 12 lead ECG showing the atrial, some form of your P waves are not there, but the RR is regular. Then they will ask you what are the causes of regular RR in a patient with atrial fibrillation, and you have only two differential diagnoses. One is in a AF, you get a complete heart block, or in a patient with AF who has digitalis toxicity. So AF with digitalis toxicity and complete heart block has not a regular RR which is regular. Third question which they may ask you is how whether you have taken 3 BP recordings or 3 pulse recordings in a patient with atrial fibrillation, which is actually a must. So in this clinical examination, you should do these few things, which is very important. So there are types of atrial fibrillation like the paroxysmal, which lasts less than 7 days. So most of the time the name tells paroxysmal, we think that it doesn't need any treatment. No, it is not like that. Even with a treatment, if the AF lasts less than 7 days and it doesn't recur after 7 days, it is a paroxysmal AF. Persistent is something which is more than 7 days and needs either chemical or DC cardioversion to terminate it. Long standing is something which is more than 1 year, and a permanent is in which the restoration and to the sinus rhythm and maintenance has failed and even not attempted. And the evidence says that in a permanent AF, we should not try to cardiovert or give drugs for maintaining sinus rhythm. We should just try to achieve the good rate control and give anticoagulation to the patient. And to tell a patient has a clinical AF, the AF should last at least 30 seconds on a ECG or on a whole 24-hour Holter monitoring. So that is something which is very important. So you can have a fine fibrillatory waves which are less than 0.5 millivolt and a coarse fibrillatory waves which are more than 0.5 millivolt. Now, this is something which may ask you again a question for a gold medal is what is a Asman phenomenon? Normally, we know in a patient with atrial fibrillation, there are both short RR cycles and there are both long RR cycles. Now, suppose this is here the RR cycles are short. Now, suppose suddenly after this there is a long RR cycle. After this long RR cycle, again there is a short RR where after which the patient has an aberrancy, and this aberrancy is of a RBPB morphology. So what is Asman phenomenon? In a patient with atrial fibrillation, following the long RR, after a short RR, following the long RR and short RR sequence, a RBPB type of aberrancy is usually known as Asman phenomenon. Now, why this is happening is, we know the His bundle usually will be in the refractory period. The longer the RR, the more the refractory period of the His bundle. So in this, here the refractory period of His bundle will be long. Until here the His will still be refractory. So the patient will have an aberrant type of conduction, which is the RBBB. And why it is RBBB? Because the right bundle branch block has a longer refractory period compared to the left bundle, and so the patient has a RBBB type of occurrence. So this is something which is little at a higher level, and somebody who wants a gold medal can definitely try to remember it. Other people also remember it, but we can try to keep at least minimum things which we should definitely know. So those things which we should know. Now let's see about a atrial flutter. Now this arrhythmia is not as common as a atrial fibrillation, but you will definitely encounter you many times in your ICUs and the ward. One important thing which I would like to tell you is most of the time you may not be able to see a typical flutter where you have a flutter wave which are sawtooth pattern, which are negative in the inferior leaves. Then you call it typical flutter because it is counterclockwise, and atypical flutter which are positive in the inferior leaves. Many a time you will just see a narrow QRS tachycardia which is regular at a rate of around 150. Always remember, any narrow QRS tachycardia at a rate of 150, always consider atrial flutter as the differential diagnosis. If you are not able to make out the P waves, or even if you can make out one P wave on the ECG, means the P wave should not be like a sinus rhythm, but it should be like a SVT. So in that type of case, you should always consider atrial flutter. What you have to do is give a carotid sinus massage or adenosine. You will be able to bring out the flutter waves. The flutter usually, you will be able to bring out the flutter waves, and then again it will go back to the high rate. So that is something which you should always do. Now, as I told you, the atrial flutter is usually found in a dilated right atria most of the time, and the atria rate is very high, around 200 to 350. It is very high as compared to even atrial fibrillation. Now, there are different types. The most common type which you should remember is a counterclockwise. The atrial flutter needs something known as CTI, that is carotico-tricuspid isthmus. So this is the location of at the SVC RA junction. So in that junction, the atrial flutter can either move counterclockwise or can move clockwise. Counterclockwise is most common. So you get a negative flutter wave in the 2, 3 and AVF, and there is no isoelectric segment in between. That is the most common seen in 90%. In 10%, you see a clockwise. That is a positive flutter waves in the inferior leads. So that is something which you should know. Now, as I told you, you can see in the lead 2 and 3 and AVF, you can see there is a negative flutter waves and there is no isoelectric line in between. And this is a counterclockwise flutter. And this is a clockwise flutter. You can see a positive flutter waves in the inferior leads, 2, 3 AVF. So this is how a flutter looks. Now, one important thing is you should know that for all practical purposes, management of atrial fibrillation remains the same. Flutter remains the same as atrial fibrillation. And wherever you have to give anticoagulation in a fibrillation, you should also give anticoagulation in a flutter. Manage with the same drugs like the amiodarone in a structurally abnormal heart, and flecainide, propafenone, ibutalide and all in a structurally normal heart. So the management remains the same. And for drug rate control, you can give beta blocker, calcium channel blockers. So that is one thing you should know. Our next arrhythmia is something which is known as the atrial tachycardia. And why it is atrial tachycardia? Most commonly it arises in either a left atrium or a right atrium. Sometimes it can also arise in the vena cavas or the pulmonary veins. So it can be of different types, known as the focal atrial tachycardia or intra-atrial tachycardia, but the most common is the focal atrial tachycardia. Now, as I discussed in the last class, the mechanisms of both the ventricular tachycardia and atrial tachycardia can be all three. They can be triggered activity, they can be automaticity, or they can be re-entry. But they are usually the micro re-entry. Now, few things which are very typical of atrial tachycardia is the P wave of different morphology. So whenever atrial tachycardia is started on ECG, the P wave morphology will be different from the preceding sinus wave P wave, sinus rhythm P wave. So that is something which you should know. A P wave morphology will be different, and even among the tachycardia waves, the P wave morphology will be different. The PR can vary. The PR interval usually varies in a atrial tachycardia. Atrial rates are something like 120 to 200, and that is where we also have to consider a differential of multifocal atrial tachycardia, which we see in patients with COPD, but MAT is irregular. Atrial tachycardia is regular because most of the time it is 1:1 conduction. Sometimes if there is an AV block, then 1:1 conduction is not AV block, then we have irregular atrial tachycardia. That is something which again you should know. But AV block in a atrial tachycardia, most commonly it is seen in a digitalis toxicity. Again, a MCQ question and a exam, they will ask you what is the most common arrhythmia seen in digitalis toxicity. It is a paroxysmal atrial tachycardia with AV block. So that is again something which you should know. But most commonly you should know it is a 1:1 conduction, and that is why it is regular. Now again I told you have to see with adenosine. Adenosine can occasionally stop tachycardia, but for all practical purpose, adenosine doesn't terminate a atrial tachycardia. It only terminates a AV NRT followed by AV RT. Digitalis toxicity can cause all the types of arrhythmia. Again in a MCQ they can ask which type of arrhythmia is not caused by digitalis. It is a type 2 morbid. So type 2 morbid is not caused by digitalis, otherwise it can cause all the arrhythmia, most commonly the paroxysmal atrial tachycardia with AV block. Now this is something which you should know. How do you differentiate LA origin and RA origin of SVT or a atrial tachycardia? See the lead V1 and see the lead AVL. Now you can see this image. So if it is arising from the RA, it is going from the SA node to the AV node, and it is going away from the RA. So this is going away from the RA, and so in the lead V1 it is negative. Okay, so in lead V1 it is negative because we know lead V1 is somewhere here. Lead V1 is somewhere here. It is going away towards the AV node. So lead V1 is somewhere here. Now you see the left atria. Lead V1 is here. So lead V1 is here. If it is arising from the left atria, it has to be like this. It has to be like this. So if it is arising from the left atria, it will be positive in lead V1. So if it is arising from the right atria, it is going away from the V1, so it is negative. If it is arising from the left atria, it is going towards the V1, which is positive. So that is something which is very important. Now let's again see the AVL. If you see the lead AVL, AVL is a lateral. So if it is going away from the RA, starting from the RA, it means it is towards the AVL, it is positive. And then if it is again, if it is left atria, it is away from the LA, so it is negative in AVL. So this is a very basic thing, but you should know this thing. So the origin depending on the lead V1. Now see this ECG. You can again there is I will only describe this ECG. This is a 12 lead ECG, and there is no doubt it is a narrow QRS tachycardia. Next thing is, are you able to make out a P wave? So you see all the leads, is a P wave visible, but always for all practical reason, always remember, if you want to see a P wave very clear, always see the lead V1. And here you see a lead V1 where you have a P wave. So in this, here the rate of the tachycardia is somewhere around 150. So it is a SVT which is regular and rate of around 150. It is a long RP. Now when it is a long RP, I told you the differential has to be atypical AV-NRT, atypical AV-RT, and then atrial tachycardia. The third thing becomes atrial tachycardia. So the atrial tachycardia in this case will be high on our differential, and see the morphology of the P wave. Now when you see the morphology of the P wave, you see that in lead V1 it is positive. In lead V1 it is positive means it is a left atrial focus. So this is a left atrial focus. Now you have to treat this with your drugs like beta blockers, calcium channel blocker. You can give adenosine, but most of the time you want to reverse. So you have to give beta blockers and calcium channel blockers. Now, as I told you, again the mechanisms are very different. Most of the time it is the automatic, and that is why it is a gradual onset. There is a warming up and there is a cooling down. And sometimes because of the automaticity, I told you, automaticity doesn't need a premature atrial or a atrial complex to initiate it. So it may not start with a premature. PVO morphologies are very different, and the first atrial tachycardia PVO after a sinus will always get different morphology from the preceding sinus rhythm. You may confuse it with the sinus tachycardia and associated adenosine insensitivity, because both are not sensitive to adenosine. But you should always remember that the sinus tachycardia arising at a 150 rate is something very unusual and triggered with isopropanol. It is a drug, isopropanol, which triggered it, but not with a programmed stimulation. This is the EP thing, and I think it's not going to the details. And the rapid stimulation may not initiate the tachycardia. Now, this focal atrial tachycardia can again be a triggered activity. It can be a triggered activity where it is a rapid onset, rapid offset, and it is usually due to delayed after depolarization, which I last time told you the mechanism, and that is why it is a catecholamine dependent, and it is activated by the sympathetic nervous system, and it can be terminated by adenosine. So a triggered activity, a focal atrial tachycardia, can be terminated with adenosine, and this is one of the arrhythmias which, if very high rate, can cause tachycardia, cardiomyopathy. So these are the few things again which you should know. Now next is one more mechanism which is also known as the micro re-entry. Now the micro re-entry is something which is not very likely to cause, but if it causes, it is termination within verapamil and initiated and terminated by pace. So this is something which you should know, but the overall big points about focal atrial tachycardia we should always know. Now this is one more type of intra-atrial re-entry tachycardia, IART. It is usually not very common because it is seen most commonly in patients with congenital heart disease who have undergone surgeries like Fontan surgeries, where the scars are made in the atria. And when the scars are made in the atria, these scars can be a nidus for micro and macro re-entry. And you see a discrete PVOs and isoelectric baseline in between. So these PVOs are of different morphology. That is something which you should know. Now, third thing which I already told you is SA nodal re-entrant tachycardia. It is a micro re-entrant, and PVO morphologies are similar to sinus tachycardia. So sometimes it becomes very difficult to distinguish it from a sinus rhythm. Usually precipitated and terminated by premature complexes, and atria rate is around 120 to 150. So it is usually looks like a sinus rhythm, and stops and starts abruptly, and AV block can still occur in this. Now next thing is something which you should be knowing, because it is very common in the bedside patient, like a COPD patient, sepsis patient, and even heart failure patients. It is known as a multifocal atrial tachycardia. Heart rate is between around 120 to 200, and its activation is from a multiple focus, and that is why you get different morphology of PVOs. So at least 3 different PVO morphologies should be there, and it is usually exacerbated by drugs like astatine, theophylline, which you give in COPD patients. And this ECG you can see. And most important thing is it is an irregular rhythm. You see an irregular rhythm, your first thing is you will call it a atrial fibrillation. Don't do that mistake. Always see different morphologies of the PVO. So here you can see different morphology of the PVO. You have multiple PVOs and different morphology, and that is why it is a multifocal atrial tachycardia. Most of the time you may not be able to give drugs like beta blocker because this will be COPD patient. Try to give calcium channel blocker. These are good drugs. Even digoxin can help in such cases. Now, any doubts are there? I'll wait for a minute. Then we'll go to the next group of this thing. Sanket, if anything you want me to repeat, just tell. Otherwise, I'll proceed to that.
No, sir. I have not got any message yet. But I think if you can still, Matt, we have discussed. Can you discuss a little about wandering pacemaker? What they are commonly together?
See, I just one thing I wanted to tell you: a wandering pacemaker is something people, for practical purposes, call a wandering pacemaker a Matt with rate less than 100. But a wandering pacemaker has just now become a theoretical thing, and it doesn't have any practical relevance at present. But whenever you see a Matt like ECG with a rate of less than 100, it is a wandering pacemaker. So that is what something. So people will, there is no clinical relevance, but a mat with the atrial rate less than 100 is called a wandering pacemaker. Again, because the PVO morphologies arise from the different focuses, and that is why the rate is PVO morphologies and are different, but the rate remains less than 100.
As such, we do not use beta blocker so profoundly in COPD and all.
Right.
But like this mat-like thing is possible there. And along with that, if a patient is on beta blocker, is it possible to have this kind of picture of wandering pacemaker, or it is the hypoxia kind of thing of COPD which actually leads to mat picture because of hypoxia-induced tachycardia? Like thing?
Yeah. It is because of hypoxia only.
Right. So it is here.
Yeah. No. Actually, no. That is not there. What is it? People who are mat on beta blocker, they may not lead to wandering in the pacemaker because the mechanism there is something different.
Correct.
Mat has an underlying precipitant. My wandering pacemaker doesn't have an underlying precipitant.
Oh, okay. So if you put on that, it is not something like we will get it, right? Okay. So sometimes, sir, we see the ECG of wandering pacemaker kind of we diagnose like also an ECG crazily, and
one of the most common differential of wandering pacemaker is ectopic atrial rhythm. Just remember, because there again the rate will be less than 100, and you may see a inverted P waves in inferior lead. So when inverted P waves in inferior lead, it is a ectopic atrial rhythm, and that is a low atrial rhythm. So it can arise anywhere from your low atria or your mitral annulus or from the coronary sinus. And it is sometimes very same like a wandering pacemaker.
Yeah.
So that is one thing, one important thing you told. So I discussed. Anyway, it will come. So
yeah. So for students, if any doubt, can definitely ask or message me. I think we can continue.
Now, next, going to the important topic of discussion is AV nodal re-entrant tachycardia and atrioventricular reciprocating tachycardia. Now, again, I discussed last time the mechanism of this. Most of the people, they have only one node, means one pathway from the SA node to the AV node, and that is the fast pathway. The fast pathway, it has a fast conduction, but the refractory period is longer. Now, we know less than 1 to 2% of the population can have a extra circuit, that is a dual AV node. So in dual AV node, what happens is we have two types of pathway. One is the slow pathway and another is the fast pathway. Normally the conduction goes from the fast pathway, and that is why, and the slow pathway doesn't work. But what happens, suppose if some patient gets a premature atrial complex, in that case what will happen, after a sinus rhythm, the fast pathway will be in a refractory period, and that is why the conduction then go from the slow pathway, it reaches the ventricle, but it also form a re-entrant circuit, and as soon as the fast pathway gets off its refractory period, it goes to the fast pathway, and the cycle continues. So that is known as the AV nodal re-entrant tachycardia. It is a narrow QRS tachycardia, and most of the time you may not be able to get a P waves. So because from here to here, your slow pathway, it is going to the ventricle, your QRS forms, and by the time your QRS forms, and then and after that your atria is via the fast pathway, when it goes, your atria is activated, and that is why you get a P wave which is after the QRS, because when it goes via the QRS, you do not get a P wave, but your atria is activated from the fast pathway, and that is why you get a retrograde P wave. Most of the time it is buried in the QRS, but sometimes it is just after the QRS. That is something which you should know. Now, presence of two physiological or anatomical AV node pathway, and most of the time, around 65 to 70% of the regular SVT is AV-NRT. So that is something which you should know. And the activation is via the slow first, then fast, as I already told you. Rate is around something between 150 to 200. Most of the time we see the rate will be around 250 and up. So rates will be very high. It begins with a premature depolarization. And I already discussed, you see something known as the pseudo S and a pseudo R. See, most of the time you may not be able to get, because most of the time is P wave is buried within the QRS. If you are able to get just after the QRS, then it is seen as a negative P in a lead 3 and AVL. which is a pseudo S, and a positive P wave in lead V1, which is a pseudo R. So that is something which is very characteristic and one of the very important differential for a means. Otherwise, most of the time ECG, when you see, your diagnosis remains regular QRS tachycardia, regular short RP. Most likely it is a SVT. Then they will ask you, it is a AVRT or AVNRT. Then the points will be like, sir, there is a pseudo S and pseudo R. So I think it is a AVNRT. But it is not. It doesn't stop here. There are many other things which we have to be picked up to call it AVNRT or AVRT. So it usually stops with a vagal maneuver abruptly. So termination by a vagal maneuver like carotid sinus massage and even adenosine makes AVNRT more likely than a AVRT. 95 to 99% of AVNRT response, whereas only 80% of AVRT response to carotid sinus massage. History-wise, the important thing is AVRT is usually seen in young ages, like 20s, 30s, whereas AVNRT can usually be seen in 40 and more. Otherwise, symptoms both will present with palpitation, there won't be any giddiness, syncope or anything. Now, for AVNRT, I told you, either you may not get a P wave, or the P waves are retrograde and are inverted in lead 2-3 and AVF, which is seen as a pseudo S. Or the P waves are buried in the QRS complex and there is simultaneous activation of the atria and ventricle. That is the reason why the P waves is buried in the QRS, and that is the most common presentation. And it is in this that you won't be able to see out any P wave. However, if it is not synchronous activation, you see 30% of the cases pseudo S and pseudo R. And very rarely, around 4% of the cases, the P wave may be farther away from the QRS, where you can feel it as a long RP tachycardia. So in all the long RP tachycardia, the 4% possibility is still there that it can be AVNRT. So very rare, it may not always be possible. So, and most of the time it will be AVRT. Now you can see this, there are pseudo S waves and pseudo retrograde P waves. Sometimes the retrograde P waves are so much that they are seen as so much long RP tachycardia. So this clinical picture is very rare. And in V1 you see something known as a pseudo R wave. So this is something which you should remember. And I already told you, 60% of the cases you do not see a P wave. 30% of the cases you see is very rare. You seeing a pseudo Q wave is very rare. Again, a retrograde P wave. This can be one of the things, but here the diagnosis of AVRT becomes more likely. If you see a P wave which is little away from the QRS and inverted in the inferior lead, and it is a short RP, but RP is around more than 80 milliseconds. Short RP, but RP is more than 70 to 80 milliseconds. The first diagnosis is AVRT and not the AVNRT. However, if you see some picture like this, as I already told you, long RP tachycardia, atypical AVRT and atypical AVNRT, also known as PJRT, are down in the list. The first differential becomes a focal atrial tachycardia. Right? So till now, you should have a very clear picture in the mind. Now, when you get that arrhythmia, give the patient first a carotid sinus massage. You give a carotid sinus massage for 10 to 20 milliseconds first on the right side, and if it doesn't respond, give on the left side. Make sure that the patient is not sitting. The patient should be lying down. Sometimes the people also respond to Valsalva maneuver. Sometimes the patient of AVNRT, you are telling that once you go home and if you get a tachycardia, always teach them how to do a Valsalva. Sometimes this also responds to a Valsalva maneuver. Also, we do something known as the oculocephalic reflex, but it doesn't work most of the time. And sometimes what we tell is, if you put a cold water on the face, the AVNRT can go. So these are the other few tricks, but you have to give a adenosine, and the termination with the adenosine is very important. You can see the termination. If it terminates, as I already told you, if it terminates with a P wave, then atrial tachycardia will ruled out. So you can see here it's terminating with a P wave. So atrial tachycardia is ruled out. It has to be a AVNRT or a AV. See this pseudo S and lead V1, something like a pseudo R. So this is a AVNRT ECG. Now again you can see this ECG. It is a 12 lead narrow QRS tachycardia which is regular. Again you can see lead 3 We are not able to make out in lead V1 there is something known as a pseudo R. In lead V1 we have a pseudo R. In lead V3 we do not have anything very clear, but still looks like a AVNRT because we are not able to see any PVO. So it has to be a AVNRT. But always remember, if you go by this textbook, 99% cases you will be right. But in 1% case, when you do electrophysiological test, you may get something new diagnosis. So always remember, you are most of the time correct, but the reverse can also happen. Now let's discuss about AVRT. So this was all about the AVNRT. Now, as I told you, AVRT, let's discuss it via the. Okay, so I had already told you the AVRT. Most of the time, most of the patients with AVRT, they have a concealed pathway because they have only a retrograde pathway from the accessory pathway which conducts from the ventricle to the atria, but they are concealed. They do not manifest. That is the most common. If they manifest, they can manifest either via orthodromic wise or a antidromic wise. As the name suggests, orthodromic means from SA node to AV node, it goes via the normal pathway. And that is why, because it goes via the normal pathway, fast pathway, which has a lesser refractory period, it is a narrow QRS tachycardia. But when it goes from the ventricle to the atria, it goes via the accessory pathway. That is why, and that is suggested by the RP interval. So we have a short PR. The PR is very short. And there is a RP which is little wider. So the RP of this is because this is via the accessory pathway and the refractory period is large. And that is why, as compared to AVNRT, the RP is longer because it doesn't cause a simultaneous activation of the atria. That is one thing which you have to remember. Now, when you see something known as the antidromic, see, most of the time, 60% of the time, it has to be orthodromic tachycardia. Antidromic tachycardia is very rare. It is seen around 10% of the cases. Now, in antidromic, the conduction from the atria to the ventricle happens via the accessory pathway, which is denoted by the PR. And that is why you say that in a WPW syndrome, the PR is usually short. Because the atria to ventricle, you get something known as short PR. And this short PR is because of this QRS. You get a slur in the QRS, which is a delta wave. And why we get a delta wave? Because it travels via the accessory pathway. It is like a muscle conduction, like you get a ventricular tachycardia via the myocardium. It is similar like that, and that is why you get a slurring in the QRS. And because this accessory pathway have a faster, longer refractory period, the QRS is wider. So these are the two things which are important, and a short PR interval. And you get a other conduction from the ventricle to the atria via the normal path. So that is something which is important. Now, again going to the basic, there are two types, typical or atypical. Typical when the RP is less than PR, and the atypical when the RP is more than PR. I told you atypical AVRT is usually not very common. It happens, it is known as a PJRT, that is permanent junctional reciprocating tachycardia. You just remember it as a atypical AVRT. Most of the time in AVRT, you will be able to see a P wave, a retrograde P wave in the inferior lead, which is more than 70 milliseconds. Now, as I already told you, if it is a concealed bypass tract, it causes only retrograde conduction via from the ventricle to the atria. And if it manifests, it has to do both antegrade and retrograde, as I already told you. In that case, it can be either orthodromic or it can be antidromic. One of the important thing which is how to differentiate AVRT from AVNRT is the rate of AVRT is usually very low, and that is why we see something known as the QRS alternance. So in the ECG, if you are able to see some alternance of the QRS amplitude, which is varying, it usually suggests AVRT. Second, if you see diffuse ST depression, that the ST depression in the ECG is too much in the lateral leads and all, again it suggests AVRT. But you should know that both of these characteristics is because of the rate and not as per se because of the arrhythmia. Also, one important thing is AVR will be positive sometimes in the AVRT. So these are the few things apart from a longer RP which you should be able to differentiate from a AVNRT. Now, as I told you, if you have a left-sided bypass tract and a right-sided bypass tract, So in a left side bypass tract, the P waves are negative in lead 1 during the tachycardia, because it from the left to it is the left sided pathway, and in the in lead 1, if you are getting a positive wave, it is a right sided bypass tract. This I will come into some other class when we discuss this bypass tracts. Now, one important thing is AVRT is usually a re-entrant, macro re-entrant. By there is a accessory pathway. So as I have told you, there is something known as the WPW syndrome, and when a pre-excitation manifests, it is called a WPW. This WPW usually have a short PR, delta Q wave, and broad QRS. Now, there are different types, left side and right side. We'll discuss in some other class. But in ECG, what you have to see is QRS alternance, ST depressions in the all throughout the ECG, mainly lateral leads, and AVR, which is positive. So these are the things which give the idea that it is a AVRT. Again, I told you, if you do adenosine like AVNRT, AVRT will also respond 80 to 85% of the times. As I told you, WPW syndrome, most of the time they do not manifest. If they manifest, most commonly they manifest as a orthodromic, and very rarely as the antidromic, which is a wide QRS tachycardia. And they may, this wide QRS are the things which usually can precipitate AF and VF on the use of AV nodal blocker. So that is something which you should remember in a patient with AF. If they have a wide QRS tachycardia, so AF with WPW, they have a wide QRS tachycardia which is irregular. In those cases, never use the AV nodal blocking drugs, because they increase the conduction via the accessory pathway, and the patient may go into VF. So what drug should be used in such cases is something like a procainamide, or you can use the DC cardio version, but never use calcium channel blocker, beta blocker, or digoxin in such cases. This I have already discussed you about the orthodromic and antidromic. Now this is one of the narrow QRS tachycardia, which is regular. You can see one thing. I think if you are able to see, we are not able to see a P waves clearly. So you will think that it is the AVNRT, but something which you see there is a QRS alternance, which is very obvious here. So this QRS alternance and the ST depression diffuse on the ECG is usually a feature of AVRT. Again, if you get this ECG, just tell it is a 12-lead ECG, wide QRS tachycardia, which is regular, which is a short RP. My differential will be both AVRT and AVNRT. Then they will ask you, what do you think? You think because it is a short RP, I think it can be AVNRT, but things like QRS alternance and ST depression may suggest that it is a AVRT. Then they will ask you, how will you manage? You will tell, I will give a carotid sinus massage followed by adenosine. If it responds to adenosine, it can both be AVRT and AVNRT. If by ECG there is no way actually you can differentiate after a termination by the way of termination AVRT and AVNRT, because both will terminate with a P wave, and termination with a QRS won't, also P and a QRS won't differentiate. Now there are other pre-excitation syndrome, which I won't go into detail. There are various fibers, like most common is the Kent fiber. Other thing can be Mahem fiber, which goes from the atria to the fascicula. It connects the right atria or left atria to the right bundle branch, bypassing the AV node. Because it bypasses the AV node, it has a decremental property and it has a short PR, but it doesn't manifest as a pre-excitation because it bypasses the AV node. I told you about one thing is the atypical AVRT. This atypical AVRT is also known as a permanent junction reciprocating tachycardia. You always remember that this type of ECGs are usually seen in children, in infancy and young children around 3 to 4 years. And most of these kids present with tachycardia cardiomyopathy because their rates are very high. Tachycardia cardiomyopathy. One important thing is they will have a negative P wave in the inferior, long RP tachycardia with negative P waves in the inferior leads. So it is a long RP tachycardia. Second important thing is they are usually not precipitated. It is usually followed by preceded by a sinus rhythm. So if you see the initiation, if you are able to see the initiation of this tachycardia, it is usually initiated preceded by a sinus rhythm and not by a premature atrial complex. By the way of termination, you may not be able to differentiate. By the way of its initiation, you can tell. If it is initiated by a sinus rhythm, it is usually a TJRT. And if you terminate this tachycardia, most of these kids recover and their LV function also recovers. So you can see a long RP tachycardia which has a negative P wave in the inferior lead and a positive P wave in the lead AVL. That is one thing which is very important. Now again, there is one tachycardia which is a junctional ectopic tachycardia. It is mechanism is automatic and triggered. You may not encounter this ECGs very commonly because this is usually there are different type 1, type 2, type 3, usually seen in children and also seen post cardiac surgery. Most of the children who undergo various cardiac surgery have this type of ECG known as a junctional ectopic tachycardia. And sometimes even in digoxin toxicity and myocarditis. So what happens is it usually does not respond to adenosine. This is one tachycardia doesn't respond to adenosine, and it usually even doesn't respond many a times even your DC cardioversion. You have to give some other drugs, or even you have to give sometimes it can be caused by hypothermia, and also if you give a hypothermia, then the child may come out of this arrhythmia. And one important thing which is seen in this is SVT with AV dissociation. One of the things which again SVT, when SVT can cause AV dissociation, is a junctional ectopic tachycardia. Not very common. Somebody asks you if you know this. Again, it's a gold medal question for you. Now, how do this various narrow QRS tachycardia can present? It can present with abrupt rapid palpitation. It can present with dizziness if your rate is more than 300 and all. Syncope, again, if very fast rate. They may present with dyspnea, chest discomfort. If it relieves with vagal maneuver, it is usually AVNRT or AVRT. If you see a Cannon waveos, also known as frog sign, it means the atria is contracting against a closed or tricuspid valve. It is very typical of a AVNRT. The diagnosis is AVNRT. If you see a irregular pulse, apex pulse deficit more than 10, it is a atrial fibrillation. And X waves will be absent in the JVP, varying intensity of the first heart sound will be there. Flutters behave most of the time like fibrillation. Again, AVNRT, you get something known as the frog sign. In AVRT, it may not be able to see clinically. There may not be much sign. So these are few clinical diagnostic things for this thing. Now let's see a narrow QRS tachycardia, sinus rate more than 100. Automaticity, again I told you, a sinus tachycardia, focal atrial tachycardia, multifocal atrial tachycardia, and a junctional tachycardia. These are the automaticity. Re-entry, AVRT, AVNRT, again intra-atrial tachycardia and sino-atrial tachycardia, re-entry. Flutters and fibrillations are mostly re-entry tachycardia. Rate of flutter is around 300 to 350, fibrillation is around 50 to 100 lesser than the flutter. What we discussed in the beginning, again let's have a look. Irregular is usually three differential: fibrillation, flutter with variable conduction, and multifocal atrial tachycardia. Regular RR is all your SVTs, sinus tachycardia, and flutter with 2:1 block. If your P waves are absent, most of the time it will be a AVNRT. Rarely it can be a junctional tachycardia. P waves are present, again it can be both AVNRT, AVRT. It can be flutter with 2:1 conduction, which has a heart rate of around 150, as I already discussed, and it can be a sinus tachycardia. If your P waves are upright in lead 2, then it has to be either a sinus tachycardia or a focal atrial tachycardia. If it is retrograde, then you have to think whether the P waves are in front of the QRS and the RP is more than PR. In that case, the typical diagnosis is a focal atrial tachycardia and atypical AVNRT and atypical AVRT. If the RP is less than PR, typical diagnosis is typical AVRT, typical AVNRT, and rarely atrial tachycardia. Sometimes a flutter with 2:1. Flutter is something which you will be able to make out most of the time, except when the SVT has a heart rate of around 150, that time. Otherwise, all other time you will be able to make out a flutter wave. If you have a blocks or higher, then always think that atrial tachycardia can have blocks, flutter can have blocks, and junctional tachycardia can have blocks. So this is your differential diagnosis for narrow QRS. Again, as I discussed, this is the baseline. If you are not seeing any P wave, it is mostly a AVNRT or a junctional tachycardia. If you are able to see a P wave, mostly it is a AVRT, and rarely, and also it can be AVNRT. Atrial tachycardia is very rare. If you are finding a long RP, it has to be most commonly a atrial tachycardia, atypical AVRT, also known as PJRT, or atypical AVNRT, which is very rare. This is the same ECG. Again, I won't go into the same thing. Now, as I already discussed, a systematic approach is important. This is the same thing which I have discussed. So, relative position of P wave and RR interval we have already discussed. Mode of initiation, a gradual onset, gradual offset tells it is because of automaticity, and the arrhythmias are the sinus tachycardia, atrial tachycardia, and junctional ectopic tachycardia. Sudden onsets are re-entry and triggered activity. So they are AVNRT, AVRT, your flutters, fibrillations, and other atrial tachycardia. And I already told you the mode of initiation. If after a sinus rhythm, if the onset of tachycardia changes the P wave morphology, and there is a no change in P wave morphology, and the cycle length also changes, then sometimes that tachycardia is a atrial tachycardia. How does it terminate is important. As I already discussed, if it terminates with a P wave, atrial tachycardia you can rule out, but you cannot rule out whether it is a AVNRT or a AVRT. If it is terminates with a QRS, you have no clue. It can be any of the arrhythmias. You can see here the arrhythmia terminated with a P wave. Here it terminated with a P wave, and so the diagnosis is it can't be a atrial tachycardia. Morphology of P waves I have already discussed. This is something which I was discussing. If you have a P wave which is positive in inferior lead, it is a high atrial rhythm. If it is a negative in inferior lead, here only you will get a diagnosis of a low atrial rhythm, where it can be from the coronary sinus or from the low atria or from the mitral eminence. In that case, it is very important. So in negative P wave in the inferior lead and positive in 1 and AVL means it is a low to high activation. So it is an ectopic atrial rhythm, and if it is manifest as tachycardia, it is known as ectopic atrial tachycardia. Atrial tachycardia, I already discussed with the position of P waves in AVL and P1 and how are they. MAD diagnosis we have already discussed, 3 and more P wave morphology, variable RR interval, and you get isoelectric line between the P waves. And flutter waves we have already discussed. As I already discussed, narrow QRS complexes morphology is atrial AVNRT, AVRT, atrial tachycardia. Wide is something which is an antidromic AVRT, and a VT and a SVT with aberrancy. QRS alternance mostly goes in favor of AVRT and most commonly seen in orthodromic AVRT. Rarely it can be seen in AVNRT also, but never in atrial tachycardia. I already told you response with Valsalva, mostly it is a AVNRT or a AVRT. If it terminates with the AV block, then as I already told you, if it tachycardia, if it terminates with the AV block, it is mostly AVNRT, AVRT. If it continues with the AV block, it means ventricle is not an integral part of the tachycardia service. So you can rule out AVRT. So that is something which is very important. And I discussed you, if the ratio of atria is more than ventricle, then if the diagnosis is flutter or atrial tachycardia. If A equal to V, it is AVNRT, AVRT can be atrial tachycardia. But if A is less than V, it means there is a AV dissociation. V more than A means AV dissociation. AVNRT, that is junctional ectopic tachycardia. AVNRT can have AV dissociation, junctional tachycardia can have AV dissociation. One type of AVRT known as the nodofascicular tachycardia can have AV dissociation. So this is not very important, but you should just know it.